questions for you, Sally. I'm going to kick off first of all, before I start looking in the chat box. You can see a question that's come up there, and I want to thank Caroline Meyer for providing us with a whole load of questions, and these first batch are from her. So I'll quickly read this out. These are mainly concerned with COVID, because I think that a lot of people are concerned about this whole area. Given the difficulty of satisfactory and effective protection from the vaccine alone, I'm a CEV and have now had 4 jabs, is it now time, whilst my 4th jab is very recent, so protection from vaccination will be at the maximum possible for me, to take the government's advice and learn to live with the virus? This would mean having contact in more risky ways, blah, 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 potentially culminating in catching the virus, which would, of course, add the benefit of natural immunity to the limited protection given to my vaccination. So if you can answer that question, and also talk about the 4th jab, because some of us don't know about that.
Thank you. So I think that's a really difficult question, isn't it? And there's been a lot of discussion about the government's plans to lift all restrictions within the next couple of months, and as you say, learn to live with the virus, and what that means for populations of people who are vulnerable. I think a lot of that, so I say a couple of things. Number one, there's no doubt that vaccination has transformed our expectations for our patients from COVID infection. You know, when I compare what's happened in this last surge with Omicron compared to what we saw in the first and second stage surges, there's really no comparison. Just as an example, I'll give you, in the first and the second surges, we had very few dialysis patients, for example, who stayed well and remained out of hospital who were infected. We just had lots and lots and lots of inpatients. During Omicron, we had 100 dialysis patients. I think we peaked at 104 dialysis patients who were infected with COVID, but weren't unwell enough to need admission. So they were at home and they were attending the dialysis units, and they never got sick enough to need admission. And obviously there's been further innovations now. Anyone who's on dialysis or had a transplant should have been contacted about now the COVID medicines delivery units and the treatment. If you get COVID and you're a vulnerable patient, the treatment that now can either be couriered to you at home as a tablet, or where you go into one of the centers and have an infusion, and that's it, and that gives you additional protection. So I think, you know, we've come an awfully long way in a very short space of time, and things have changed an awful lot, and new innovations are happening all the time. And we know so much more about this virus than we did at the beginning. And as I say already, none of us can predict the ways in which the virus is going to mutate, but generally, it's probably fair to say, in terms of the natural history of viruses, that they usually become less virulent or less harmful with time. And it's certainly what we've seen with Omicron. So I think if we have to hope that that's going to remain the case, and that this will become something a bit more like a nasty cold that won't be so devastating for so many people in the way that it was in the first surges. But I think it's very much, you know, it's a personal choice, and we all have to balance what our different priorities are, and the answer won't be the same for everybody. It's never going to be an easy decision, but I think, you know, all people can do is get the information that they can, and then try and make the choice that best suits them and their families and so on. There's no perfect answer here. Just to talk about the 4th jab. So the plan had been that obviously anybody who is clinically vulnerable had a 3rd jab. So if you're not clinically vulnerable, your 3rd jab was called your booster. But if you are clinically vulnerable, then your 3rd jab was the 3rd dose of your immunization course, with a plan that was initially going to be for a 4th dose at 6 months. Part of COVID medicine is trying to keep up with all the changes as quickly as they come, because in December that was then revised that the 4th jab would come 3 months after the third jab. So that's where we are now. We haven't had any formal government comms from that. We spend a lot of time writing to all our patients. We've only just written to everybody about the home medicines for COVID. But that's something that's going to be coming up, I think, quite soon. And actually, I have got one patient who's actually had her 4th jab. So she's the first person I've heard of who's actually already received a 4th dose.
Okay. Before I go on to Caroline's questions, I'm going to just break up the one here from Jeremy. Repatient transport, do you feel that the fact that this is organised and funded on a group basis with several other hospitals works to
bu hepsi?
Martin, can you put yourself on mute, please?
Okay, sorry.
Thank you very much.
You're welcome.
Does it work to roll-free patients' advantage, or would it be better if roll-free could contract exclusively on its own behalf? If so, could this be done within existing budgets, or could it cost more money? Yeah, I know the answer to that. Over to you, Sally.
Yeah, I think it's in a way that's a question above my pay grade, but it's a huge and complicated service. And I think, as I said, I think there's generally recognition. There's two things. One is, are there efficiencies and improvements that can be made within the existing service? And there probably are to a certain extent. And then secondly, actually, is some of this just limited by the fact that the capacity is inadequate? And the more we look at it, the more it seems clear that there is a capacity question here. It can't be okay for people to be waiting 2.5 hours after they finish dialysis to be collected. Could the roll-free contract? I think that would be very expensive, complicated, and difficult, I suspect, Jeremy. But it's a good question.
Yeah, and you've got to remember, Jeremy, I'm sure I've made this point before, but the cost of this is paid by the commissioning groups. So technically, the roll-free doesn't pay for this. And putting the 4 hospitals that are part of this contract together supposedly makes it cost effective. In reality, someone's not on mute. Please put yourself on mute. And it's probably Martin again. Yeah, Martin, you need to be on mute.
Okay.
Okay. Anyway, point made. We can talk more about that, Jeremy, on another occasion. Mina, you've got your hand up. Mina? Mina, you've got a question. Do you want to ask it? Do you want to unmute yourself? No, okay, I'm moving on, Mina, because you don't appear to be hearing. Okay, question number 2. Has satisfactory effective vaccination of CEV people is proving so difficult? Why are they not being offered periodic preventative treatment of monoclonal antibodies, e.g. Sotrovimab, please?
So I think I'm not aware of any data about the preventative benefits of some of the monoclonal antibodies. So the ways in which they're generally used is for treatment. And I think it would be, they're given intravenously. So I think that would be quite a significant undertaking. And I don't know about any data in terms of efficacy or how often you'd have to give them, because obviously you give antibodies, they last for a fixed period of time and they give you some benefit while you've got the infection. But how often would you have to give them if you wanted to top up your antibody levels all the time intravenously with an infusion? I think that would be a huge logistical undertaking. I think probably the benefits of that would be unclear.
Okay, thank you. I'll butt in amongst these questions on the screen for one from Mario Angeli. My dad does dialysis and cannot have a transplant. Here's the impossible question. Will he always be on dialysis? Can you tell me of any developments in dialysis that could help with side effects and to extend life expectancy? Thank you.
I think that's a really excellent question. I think there are, I think there are innovations in dialysis and things changing that maybe will have, beneficial effects for patients. When I was an SHO, I think starting at the Royal Free, I don't know how many of you know this, Andrew Davenport was involved in research looking at the wearable artificial kidney. I don't know if any of you, so it's kind of a kidney that you wear on a belt and wander around, and that's never really taken off, but there's lots of research going on in terms of, you'll often see things on the BBC about synthesizing artificial kidneys and all of these kinds of things. None of that is nearby, none of that is close to us in time in terms of being able to deliver it. But I think there are things that come along that help to improve quality and quantity of life for dialysis patients. Some things about quality of life are things like transport, to be honest, that that can have a hugely detrimental effect on patients if it doesn't work well. Home hemodialysis is something that can improve quality of life for patients, both because it cuts out some of the toing and froing, but also actually because home hemo patients often do more hours on dialysis in total. I know some of you are very familiar with home hemodialysis, and those patients often have fewer of the side effects related to bone metabolism or fluid and blood pressure problems and so on, so that can be beneficial. There are new treatments that come along, so for example, some of the treatments for renal bone disease, we've got an injectable version now that we give on dialysis that seems to be much more effective, so that's a beneficial thing. We've got more phosphate binders than we used to have. There's been some successful trials now of a new medication for itch in dialysis patients. Doesn't sound important, but obviously if you itch a lot, that's a terrible thing for your quality of life and can be very distressing indeed for patients. So I think there are things happening and I think there are things changing, but I think it's a really, really good question. And I think how to do that. Another example is, for example, moving from hemodialysis to hemodiafiltration, which is a kind of technical distinction for dialysis experts like Andrew Davenport, really, but it does give patients better quality dialysis, and we think that's related to better outcomes. So there's lots of effort and lots of moves towards it. And I think it's small and incremental things. If one day there is a wearable artificial kidney, that will be transformational, but that's not in sight just yet.
Okay. Just a question about home hemo. What are the reasons why we've got so few of our patients on home hemo? And is it a cost problem, or is it just that we're not very good at trying to persuade patients to switch over in that way?
So again, another really good question. I know home hemo is close to your heart, David, and I would agree with you. I think we've done very well in home therapies in total, and in fact we've exceeded what the GIRF targets are for the proportion of our patients on home therapies, which is at least 20%. But that's largely peritoneal dialysis. And I think we've always been very strong in PD, but I think, and it's definitely not the cost, because the cost is still very favorable compared to in-center hemodialysis. And it can be, for some patients, it works really, really well. So I think that's an area that we should work on. I've had conversations with Robin Hodgson, who's our lead home therapies nurse, as I think you have as well. But I think we're doing really well on PD. Home hemo is the area that we need to work on, because our numbers have actually gone down a little bit.
Okay, all right. Well, obviously, we want to be involved in any way we can in helping that. Just to say that apart from Jeremy thanking for the answer earlier, Mario has said, that's given me lots of encouragement. Thank you, Sally. So thanks for doing that, Mario. On this question number 3, you've already tackled this area, but I guess it would be good if you can answer if that is the drug, the drug molnupiravir. I've never heard of that.
So it's actually molnupiravir. So these are the treatments that you can have out of hospital if you're a vulnerable patient and you catch COVID and you're not unwell enough to need admission. You can be offered 2 treatments. One is a tablet antiviral treatment, that's the molnupiravir, and the other one is the sotrovimab, which is a monoclonal antibody that's given by injection. the person who asked the question is correct, that it looks like the efficacy that sotrovimab is more effective, but because it requires going in physically to the unit and having an intravenous infusion, those systems have been much slower, more slow to be set up. So all the patients so far that we have sent to the COVID delivery centres to have treatment at home have been given molnupiravir. And the good thing about that is you don't have to leave your home, so they courier the tablets to your house. And it's not quite as effective as the injectables, but they're not at the moment, actually, as far as I'm aware, been widely available, but they are certainly of some benefit. And it's a short course of, I'm not aware of any issues with cancer risk or side effects for bones and so on, has been said here, for the very short courses that are being advocated for COVID treatments. I'm not familiar with long-term use of these or any of that other cancer data, but we're talking about a short treatment course for people who've got COVID here.
Right, okay. If we don't expose ourselves now, surely in March, when people who test positive for COVID no longer have to self-isolate, we would be at far greater risk. Or would I be anyway, as it will be 10 weeks after my 4th jab?
So I think, I don't think anyone should go out now just to kind of get exposed. We don't know what's going to happen after the 4th jab, because obviously we haven't got any data yet. But what we do know is that the levels of antibody and the duration of immunity seems to increase with the more doses you have. So protection from Omicron, as you probably know, isn't very good after 2 doses, but after 3 doses, it goes up quite significantly to about, I think, it's between 60 and 80%, I think, and the antibodies are more long lasting. So you would hope that after the 4th jab, again, constant stimulation of the immune system, that there will be some longer lasting protection. But we don't know yet because we haven't seen the data, because there aren't many people who've had 4 doses.
Okay, thank you. The last point on here, I understand the state-owned vaccine manufacturing and innovation centre is to be sold into the private sector. Does that bother you in any way?
Well, I have to confess that's not something that I've heard about or that I know anything about, actually, so I'm probably not well placed to comment. The only thing I would say is that clearly COVID has been a time of really amazing public-private partnership, because obviously the AstraZeneca vaccine, in conjunction with the scientists in Oxford and the Pfizer vaccine as well, you know, we have to use all the resources that we can for the benefit of everybody's health. So I think that's probably a right way of doing things.
Okay. Do we have any more questions for Sally? Okay. Sally, thank you so much. I'm, you know, on behalf of everyone, I'm sure we're all really grateful.